Before fixing a mitral or tricuspid valve, we don't just evaluate the valve, we evaluate the entire cardiovascular system. Because in structural heart interventions, the outcome is not determined by the device alone. It is determined by understanding the physiology. Today, we will walk step by step through the full pre-procedural workup before mitral or tricuspid valve repair or replacement. And more importantly, we will understand why each test matters. Let's start with echocardiography. Echocardiography is the foundation. We use transthoracic echocardiography, or TTE, which is the standard ultrasound performed on the chest, and transesophageal echocardiography, or TEE, where the probe is placed in the esophagus to get higher resolution images. These modalities allow us to assess both severity and anatomy. For mitral regurgitation, we quantify severity using parameters such as effective regurgitant orifice area, or EROA. An EROA greater than or equal to 0.4 square centimeters defines severe mitral regurgitation. We also evaluate regurgitant volume, typically greater than 60 milliliters for severe disease. But beyond severity, anatomy is critical. We assess leaflet mobility, calcification, coaptation length, and jet location. For transcatheter edge-to-edge repair, or TEER, adequate leaflet tissue and central jet location are favorable. If leaflet anatomy is complex or there is severe calcification, the patient may be better suited for transcatheter mitral valve replacement, or TMVR. For tricuspid regurgitation, we assess annular dilation, leaflet tethering, and right atrial and right ventricular enlargement. Severe tricuspid regurgitation is typically associated with large annular dilation and poor leaflet coaptation. So echo answers the first key question: is the anatomy suitable for repair or replacement? Next, we move to invasive hemodynamics with right heart catheterization. This is where physiology becomes measurable. We measure mean pulmonary artery pressure, or mPAP. Normal mPAP is less than 20 millimeters of mercury. Pulmonary hypertension is defined as mPAP greater than 20 millimeters of mercury, and clinically significant elevation often above 25. We also measure systolic pulmonary artery pressure, or sPAP. Normal sPAP is typically less than 30 to 35 millimeters of mercury. Elevated pulmonary pressures indicate increased afterload on the right ventricle. Now, the key question is, why are these pressures elevated? If pulmonary hypertension is driven by mitral regurgitation, correcting the valve will reduce pressure. But if pulmonary vascular remodeling has occurred, the pressure may remain elevated even after intervention. We then measure pulmonary capillary wedge pressure, or PCWP. PCWP reflects left atrial pressure. Normal PCWP is between 6 and 12 millimeters of mercury. Values above 15 to 18 indicate elevated left-sided filling pressures. But the waveform is even more important than the number. The PCWP waveform consists of A, X, C, X prime, V, and Y components. The A wave reflects left atrial contraction. The X descent reflects atrial relaxation. The C wave represents mitral valve closure and early ventricular contraction. The X prime descent reflects atrial expansion during ventricular systole. The V wave represents left atrial filling while the mitral valve is closed. And the Y descent reflects rapid emptying of the atrium when the mitral valve opens. In mitral regurgitation, the V wave becomes very large because blood is entering the left atrium from both the lungs and the left ventricle during systole. A large V wave strongly suggests that mitral regurgitation is driving elevated pressures. If PCWP is elevated but the V wave is not prominent, the issue is more likely due to left ventricular dysfunction. This distinction is critical, because fixing the valve will only improve the patient if the valve is the primary driver of the hemodynamic problem. Next, we assess the right ventricle. The right ventricle is highly sensitive to afterload and plays a major role in outcomes. We measure tricuspid annular plane systolic excursion, or TAPSE. A normal TAPSE is greater than or equal to 17 millimeters. Values below 17 indicate reduced right ventricular systolic function, and values below 10 indicate severe dysfunction. We also assess fractional area change, or FAC. FAC measures how much the right ventricle contracts and is considered normal when greater than or equal to 35%. We may also assess right ventricular strain using speckle tracking. Normal RV strain values are around -20 to -25%, with less negative values indicating worse function. If the right ventricle is significantly impaired, correcting the valve can increase forward flow and precipitate right ventricular failure. So RV function determines whether the patient can tolerate the intervention. Next, we evaluate the left ventricle. We assess ejection fraction, or EF, which measures systolic function. A normal EF is between 55 and 70%. Reduced EF indicates impaired contractility. But we must also assess diastolic function. Diastolic dysfunction refers to a stiff ventricle that cannot relax properly. Even with a normal EF, a stiff ventricle can cause elevated filling pressures. This results in elevated PCWP and pulmonary congestion. So if left ventricular dysfunction is the primary issue, correcting the valve may not improve symptoms. We must always ask, is the valve the cause or is it a consequence? We also evaluate biomarkers, particularly NT-proBNP, which stands for N-terminal pro-B-type natriuretic peptide. This is released in response to myocardial wall stress. Normal values are typically less than 125 picograms per milliliter in stable patients. Elevated levels indicate increased cardiac stress and volume overload. However, biomarkers are supportive and must be interpreted in context. Finally, for replacement procedures, we rely on CT imaging. Computed tomography, or CT, allows us to perform precise anatomical assessment. We evaluate annular dimensions, leaflet calcification, and vascular access. In transcatheter mitral valve replacement, we also assess the risk of left ventricular outflow tract obstruction, or LVOT obstruction. This occurs when the implanted valve obstructs blood flow from the left ventricle to the aorta and can be life-threatening. So CT is not just imaging, it is procedural planning and risk prediction. Now, when we bring all of this together, each modality answers a different question. Echocardiography tells us if the valve is anatomically treatable. Hemodynamics tells us whether the valve is the cause of the problem. Right ventricular assessment tells us if the patient can tolerate the change. Left ventricular assessment tells us if the patient will benefit. Biomarkers tell us how advanced the disease is. And CT tells us how to safely perform the procedure. Only when all of these factors align do we proceed with intervention. Because in structural heart, we do not treat valves in isolation. We treat a complex, dynamic hemodynamic system. And the difference between success and failure is not only the device, it is understanding the physiology. Because in modern medtech, the real value is not in the product, it is in the understanding. And choosing the right partner matters. Because not every representative brings value. The ones who truly understand the physiology, the data, and the full clinical journey are not salespeople. They are partners in shaping better patient outcomes. This is Ali from Medical Sales Mastery. Subscribe to learn more, and thank you for watching.